Hello and welcome to another intensivecarehotline.com and intensivecareathome.com live stream where you can ask me anything as it relates to your having a loved one in intensive care, or if you have questions about intensive care at home, or if you are thinking about intensive care at home, you can ask me anything here. I want to thank you for coming onto the call. As usual, you can type your questions into the chat pad, or you can join me live on the show here. I will send you the link how you can join me here in a minute. Just before we go into today's topic, I also want to welcome anyone that's watching this on replay. But obviously it's much better if you come here live so that you can actually ask me questions here on the show directly. Now, before we go and ask some questions today, what makes me qualified to talk about families in intensive care? What makes me qualified to answer questions for families in intensive care? I am a critical care nurse, having worked in critical care for nearly 25 years in 3 different countries, where I also worked as a nurse unit manager for over 5 years. I have been consulting and advocating for families in intensive care since 2013 as part of my intensivecarehotline.com consulting and advocacy service. And I can say without any hint of exaggeration that we have saved lives as part of our consulting and advocacy. You can look up our testimonial section at intensivecarehotline.com and see what our clients say. You can also look up our podcast section at intensivecarehotline.com and you can see what our clients say, even on a podcast, that we have saved their loved ones' lives. And that is without any exaggeration. I am also the founder and managing director of Intensive Care at Home. With Intensive Care at Home, we are sending intensive care nurses into the home to provide a genuine alternative to a long-term stay in intensive care. With Intensive Care at Home, we are currently operating all around Australia. We are an NDIS approved service provider, also TAC in Victoria, iCare New South Wales, NIISQ in Queensland, as well as a DVA approved service provider. We have also received funding through Departments of Health, private health insurance and public hospitals. We're also providing NDIS level 2 and level 3 specialist support coordination with intensive care at home. Without further ado, let's look at some questions. Let's answer some questions here. And the first question here is from Dawn. Hi, Dawn. Nice to hear from you again. I know we've spoken before. Good afternoon, Patrik. My grandmother was admitted into an LTAC for the second time. Bad experience with the first. We picked another LTAC for her because the hospital is forcing us. The current doctor won't release to an LTAC but to a SNF. She's forcing us to go there. What should we do? Well, yes, I do remember talking to you a few weeks ago, Dawn. Well, the first thing is here, if you believe you are being forced, well, that is, you are reacting to something that you may not even need to react to, right? Like I always say, the biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. And that is exactly your issue there. Dawn, I remember I was talking to you, and I think I also spoke to your mum briefly. Your biggest problem was that you let your grandmother go into LTAC in the first place. At the time you didn't sign up for my consulting, and that's okay. But don't be surprised if you're not getting the outcomes you're looking for, because I know I help people. I help people for a living, and I'm not making an excuse for it either. So what do you need to do? Okay, what you need to do is tell them she can't go anywhere without your consent, and she can't. If you let them walk all over you, then you need to take responsibility for that to happen in the first place, right? Ask for the hospital discharge policy. The hospital discharge policy will undoubtedly say that she can't go anywhere without your grandmother's or your consent as the power of attorney, undoubtedly, right? So if they're not giving you the hospital discharge policy, that means it is definitely saying that in the policy, because otherwise they would be giving you the policy if it wasn't saying that. Next, speak to health insurance and find out what her entitlements are. I find so many times that the hospitals are saying, well, she's, your family member's running out of health insurance entitlements, blah, blah, blah. And then when families speak to health insurance, or we speak to health insurance, then we find out, well, there are actually entitlements. So have you done that? Right? Have you done the work? Next, write to hospital executive, make a complaint. Right? You already know that going to LTAC or to a SNF will be an absolute disaster. You already know that. Right? For example, currently we are working with a client that we put a stop to going to LTAC, right? We've done that, and now they're making progress in ICU, right? So really, it's about taking responsibility here and not pointing towards others. Yes, they're doing what they're doing, but you need to take charge here, right? You knew that I told you that you will have a bad experience with the first LTAC. You knew that I told you, and I've been talking to people in LTAC in ICU for over 12 years and worked in those places, right? You knew that this wouldn't be a good experience. So, like picking another LTAC is like picking one toxic food after another instead of getting a healthy meal to begin with. So why would you pick another LTAC? Why? Because they're telling you to do so? Well, if they tell you to jump off a bridge, would you jump off a bridge? You can make your own decisions. You don't need them to make decisions for you. Get her back to a hospital rather than choosing another LTAC. The hospital can only force you if you accept their force. That's the only way they can force you. So if you are living in that world that they can force you, you've already lost the battle. You've already lost the battle if you think they can force you. So first thing is you need to change your mindset. Change the mindset to, well, I forced them to get her back to hospital. Turn it all around. But the first thing is you need to change your mindset. Right? So, if you think you're being forced and you accept that as your reality, continue to live in that reality. I can't help you with that if you choose to live in that reality. That's not my reality. My reality is you have choice and control. You just need to exercise it. That's the reality you need to live in. Have you written to hospital executive? Have you done that? Right? So there's already some strategies. Write to hospital executive. Get the hospital discharge policy, right? And start living in a different reality. Your reality has been, they can force us, they can do this, they can do that. That's a reality you choose to live in. Push back hard, right? So in the meantime, I will also post my link here. If you want to come onto the show talking to me live, you can join in by clicking on that link and you can talk to me directly here. Now, in the meantime, let's look at other emails that have come in this week. And there's the email from Rosalio. Rosalio says, Hi, Patrick. I'm a case manager and I have a person on my caseload that was sent to ED for assessment of lethargy. In the ED, she was found to be having non-stop silent seizures. Her airway became obstructed and they intubated her. She was also diagnosed with sepsis due to a UTI. She then was found to have sustained several moderate strokes. They have stabilized her and she is no longer having seizures. However, when they tried to extubate her last week, within an hour, they had to intubate her again. Her trachea had narrowed and they had to insert a pediatric tube. She no longer requires the ventilator, but they believe a tracheostomy is the only way forward. We questioned if she just has sustained swelling to the trachea, which could be resolved on its own. They said her narrow trachea is considered to be permanent. The tracheostomy is scheduled for the 1st of March as an elective surgery. She has an intellectual disability and lives in a group home. The group home is not sure they can take her back safely. Not sure of what to even ask, advocate for. Do want to see her wind up in a nursing home. From Rosalio. Yes, for sure. So what you need to do here is she might need a stent to have her trachea widened, right? That's what you might need. That she might need a stent, a tracheal dilation as well, right? Helene, I've seen that you're here. I'll let you in once I've answered that question. So this is what's happened here. You know, she needs a dilatation or a stent, you know, and after they've done that, then maybe she can avoid the tracheostomy, you know. And if she had moderate strokes, again, the question is how severe were those strokes? Has she had a CT scan, an MRI scan of the brain? You know, and go from there. So before she's scheduled for a tracheostomy, maybe ask for her to have a stent put in, a dilatation, right? And see whether that can avoid the tracheostomy. I hope that helps, Rosalio. Right, let's get Helene in.
Hi.
Hi, Helene, how are you?
Hi, Patrick. I'm okay. I'm glad I was able to chime in. I have a question for you. I recall my late mother experiencing fluid coming out of her mouth when we were home, and it was clear. And I was wondering, could it have been from the excessive fluid overload where she was third spacing? You can only urinate so much fluid out. Could it also come out through the mouth? Just curious.
Foam. You're saying it looked like foam?
Pardon me?
It looked like foam?
It looks like, no, it was just clear like water. It was clear.
Okay, sure.
And thin.
And at that stage, she still had a tracheostomy?
No.
No, okay.
No.
Okay. No, definitely could be from fluid overload from the chest. Definitely. Did she have difficulty breathing?
I would say at that time, no. Her O2 sats on room air was 98 to 100. I just remember one morning waking up and finding this pillow, and it was a long pillow, body pillow, and it was wet. It really scared me.
Right. Look, when someone is having fluid overload on the chest in particular, it can show up as sputum, but could also be some foamy stuff coming up. If your mom...
It wasn't foamy at all.
Okay. Was it just natural secretions from the mouth?
Well, that was my other thought, because after she was put on a, well, first of all, my mother did not have congestive heart failure or edema. It would only happen while she would be in the hospital and they gave her excessive fluid overload. But when the last year of her life, because she was only on a vent twice, 2012 and 2016. The 2016 it was so egregious that it was so much fluid, and they put her on a bypass machine, and I think it caused her, and it was excessive use. It was restrained. It was horrible for 3 days straight. No food, no water, no rest off this bypass machine. An elderly lady. And it caused her saliva glands to become overactive. So that in itself could cause aspiration pneumonia. Also, I saw a pattern happening at both hospitals when she was put on, prior to being put on any kind of respiratory failure, that when they would bathe her, they would tilt her bed where the head is down and the feet is up. So anything in the stomach can come up. And if she would be in this position, from what I could tell, for over 30 minutes. And I would have to advocate for them to put her back level or bring her head up above her heart. Once I learn about, what needs to happen. I'm sorry. I'm still traumatized from it. I wonder, could that have also caused aspiration pneumonia? Where any contents in the stomach can come up, even if it's from the excessive fluid overload, can come up and go back down, can enter into the lungs. I believe that also happened to her.
100. All of that could cause aspiration pneumonia. What I'm wondering with the saliva in particular, if she was in heart failure and her heart couldn't cope, then, the fluids would push up through the lungs. That, is one reason why you might have seen that. Was she on Lasix or on furosemide? Do you remember?
She was on Lasix in both hospitals. I know when she was in 2012, when they finally put her on Lasix, she had already been ventilated. And I recalled it took the doctor forever to put her on Lasix, where when she first went to this particular hospital, they had given her so much excessive fluid overload. She had gained 25 pounds within the first, I think it was the first 3 days she was there. And I think she went from weighing I don't quite recall, but I think 150 to 230 pounds within 30 days. It was a lot of fluid they were giving her. It was like she like a cow, honestly, that when she was on a ventilator, they had to use something like a horror from the ceiling to lift her up. I literally saw her skin splitting. That traumatized me. I just couldn't believe. And I even witnessed, can I say one more thing before I forget? I even recall when they would do when the respiratory techs would do her mouth care. I remember one nurse would put whatever it was to use to brush her teeth, but it was some kind of sponge. She left it in my mother's mouth without suctioning it out of her mouth. Can you believe that? And it said she was called and she had to rush off to another patient without suctioning that whatever they use to put in her mouth for mouth care. I just saw so much egregious stuff. It was just unbelievable. But thank God I was there to report and to hopefully one day get justice.
And thank you for sharing, Helene. This is, I know it's been a huge trauma for you all the way along. But to come back to your original question, is it third spacing? Was it third spacing that fluid's coming up? Usually third spacing means it's sort of stuck. Fluids are stuck in the tissue, and
Yes,
you would need to increase albumin levels, for it to be pushed back into the arteries and into the veins, if that makes sense.
yes, I recall when she was in 2012, they start saying, "Oh, she's third spacing," and the nurses would tell the doctors like it was like saying, "Oh, the sun is shining today," and they're the ones who caused the third spacing. That's the part that baffled me. They intentionally caused the third spacing. So she ended up when she was finally ventilated, and they trached her. Then they started discussing Lasix, and because she was septic shock, she went into septic shock as well. So I remember the respiratory doctor who was the chief of that department, was saying he did not know if LASIK will work. So they wanted to see how much urine output she was giving. And I recall later that day, I left her ICU room. And when I came back, the door was closed and I found a nurse who had just emptied her Foley bag and put the container on the floor and then kicked it so some of the urine can spill out on the floor. And she only reported what was left in the container. And I walked in on that and I said, please clean that up. And she obviously did not do a great job because that's urine. And she was septic. And that is like carrying bacteria from one place to another. Also, I said, I hope you will estimate the allowance that spilled out so they will agree to give her Lasix. And I had to go and report it to the charge nurse, the ICU charge nurse, what had occurred. And after I had done that, the nurse retaliated against me. I went through a lot of retaliation as well as my mother for reporting, but I knew I had a duty and an obligation to do it.
For sure.
And then the second time, when she was put on LASIK, it was the final year of her life. She was at a different hospital, and I recall how she ended up being admitted in 2016. She was given an antibiotic that they knew she was allergic to for pneumonia. Instead of giving her a Z-Pack, the doctor gave her an antibiotic that had sulfur in it. Penicillin, but it was another name, and I didn't even know that. And he knew it was going to cause her to have respiratory failure. Excuse me. Because pneumonia, that normally was what happens. And he instructed me, he said, if your mother, experienced respiratory failure, call 911, get her to our hospital in Fayetteville, that particular location, which was not their best respiratory facility as the one that was in Atlanta. And of course I did that. And even before she went into respiratory failure, I was asking him to, call in a Z-Pack because what he gave her was not working. And he never would call me back. When he finally called me back, she was already at this very pathetic hospital that is now closed down, on a had respiratory failure. I mean, it was just, and then, back at this particular hospital, I remember this particular doctor, this hospitalist, he ordered, well, I believe it was him because they wouldn't tell me, but I think it was this particular hospitalist ordered 2 large bottles. I mean, like large, not the little bitty ones. I'm trying to show you. It was large bottles of Lasix. And they delivered them both at the same time. but they only gave her one. Well, I'm sorry, they gave her one. And then the next day they gave her the second one, but they only recorded in the medical records one, but I witnessed them give her two. So I saw a lot of trickery going on as well. And so what I did after the second bottle, after they finished with it, they put it in the trash can. So I took it and put it back in the box and preserved it at the time. I don't know if I have it now, but that's how I had to do things. They would give her so many drugs to cause, like they were giving her sedatives and overdoses on antibiotics. It was just a lot. It was just a lot. That's why I said she was medically tortured. So I just wanted to share that. But the main part I wanted to ask more was the fact, the fluid, and again, about the third spacing, I will only hear that at these two different hospitals. Well, actually, there was a third one. They started doing the same thing. So I saw a pattern of the excessive fluid overload. And I will always try to advocate to say and there were times she wasn't even dehydrated. There was and also in the United States, I don't know if they've changed it by now, because this was reported to HHS OIG, Office of Inspector General, but there was no regulations on how much IV fluid they could give a patient. It's not even regulated by I think it's the Food and Drug Administration, not even regulated. And excessive fluid overload is like secondary drowning.
Yeah.
And I learned, I could visually see her is suffering that way, like drowning in this excessive, and also that sodium chloride caused her organs to start shrinking.
Right.
That's torture.
Sad. That's very sad. Yeah. Okay. Look, Helen, I've got some other questions here that are coming through from families
Okay.
that have loved ones in ICU now. I hope.
Yes, I understand.
Thank you for sharing, and I'm
You're
sure
welcome.
I'll see you again. All the best for now.
Definitely. Okay,
Take
thank
care.
you.
Thank you. All right, Leo, thank you so much for reaching out again with your question. And I know you've been on this show before, Leo, so I'll just read out your question here. Hi, Patrik. I'm with my father. He's still in ICU after anterior MI, ABI, acquired brain injury, and LGT. I'm not sure what LGT, I have to actually look that up. Do you have suggestions how to optimize my father's lungs? He's in a sand bed with fluids on the lungs in a vegetative state again. I do remember, Leo, that your dad was sort of in and out of consciousness. I do remember that. Now, in terms of him having an anterior MI, as well as, the brain injury, I do believe he also had a cardiac arrest from memory, but I can't quite remember. Now, how can you optimize fluids on the lungs, and then also his breathing? How can that be optimized? Well, the first thing is, if he's had an anterior MI, has he had is he on any medications for that? What is his ejection fraction? So let's just quickly focus on ejection fraction. Ejection fraction is referring to the contractility of the heart. How hard is the heart muscle beating? How can it pump blood around the body, right? That is what I mean when referring through ejection fraction. That's the medical term. I'm pretty sure he would have had an ultrasound at some point, right? What is that ejection fraction? That would be the first thing that I would ask. Because often what happens after an MI, after a heart attack, and MI stands for myocardial infarct, also known as a heart attack, right? the heart muscle is weakened, and therefore ejection fraction is going down, and therefore the contractility of the heart is going down, right? Impacting on how well the heart is pumping. So if that is the case, you know, the cardiologist should have done an ultrasound. Next, have they optimized his contractility or ejection fraction with medication? Is he, for example, on dobutamine? Is he on milrinone to optimize his ejection fraction? If no, is he on any other cardiac medication that they're giving him? Right, so he's on albumin, norepinephrine, and midodrine. Okay. Okay, so he's on inotropes. I wouldn't be surprised, Leo, if he's also on midodrine, midodrine, and also the dobutamine. So yes, so I'm on the right track here. Okay, I'm just seeing LGT stands for late generalized tuberculosis. Does your dad have tuberculosis? It's very rare that patients have tuberculosis in this day and age, but it's still around, I understand. So from that end, you know, his heart function, his cardiac function might be optimized for now with the albumin, norepinephrine, and midodrine. He might. So next thing, if he's fluid overloaded, potentially, he needs either furosemide or Lasix or any other diuretics, or he might need dialysis or hemofiltration, right? I do believe when you asked questions here last time that your dad was at least on dialysis at some point. Can you clarify whether that's still the case or not? Is he still on dialysis or hemofiltration? Right? So taking off fluids would be absolutely critical here, right? So that he can breathe better. Now, I just need to change my position here. So that is what needs to happen on that end. He needs to have fluids drained either with diuretics, such as Lasix or furosemide, or with dialysis or hemofiltration, right? That is what should be happening next for your dad. He has the anoxic brain injury. Yes, the anoxic cardiac arrest, kidney damage, and the trach. Yes, I remember that. So, with all of that said, with the kidney damage, you know, is him being off dialysis enough to get rid of the fluids? Right? That's the question here. Have you spoken to a cardiologist lately, Leo? You know, have you spoken to a cardiologist? Because what needs to happen here, Leo, is they need to get off the norepinephrine and they need to get off the midodrine, right? He has difficulty getting dialysis, blood pressure drops, heart rate goes up. They have to keep modifying amount cycle. Yeah, okay. So question is, and this is more than a play of words, is he on dialysis or is he on hemofiltration? Whilst both are doing the same, it's basically extracting fluids from the body, you know, extracting urine from the body. There's a difference whether someone has dialysis or whether someone has hemofiltration. Here's the difference. When someone is on dialysis, they're trying to remove fluids, you know, 400 or 500 mils over a very short period of time, 4 or 5 hours maximum. That means, you know, the body might decompensate, and that's why his blood pressure drops. So it's not a very gentle approach. It's actually quite a rapid approach. Whereas if your dad is having hemofiltration or CRRT, continuous renal replacement therapy, you can have a much more gentle approach. So what does that look like in practice? Once again, with dialysis, you're trying to remove 400 or 500 mils over a short period of time. Whereas with hemofiltration, you can remove 400 for 500 mils over a 24-hour period. So, you can remove 50 mils an hour, for example, right? So that is a much more gentle approach, right? And it's making it much less likely for the blood pressure to drop, right? And I'm not surprised that his heart rate also goes up during those periods. So it's about changing the approach here, Leo. Now, from what I also understand, not every ICU can do hemofiltration. Some ICUs can only do dialysis. So your dad might not be in the right ICU, unfortunately. Right? So am I making sense here? Now, other ways to potentially optimize his breathing function is, seating him up, getting him mobilized, which might be challenging on the norepinephrine and the midodrine. It might actually be challenging. He might be hemodynamically too unstable to get mobilized. He might. They're experimenting with both each time. Okay, I see. And they haven't worked out. And if he's on inotropes or vasopressors, it could be an ongoing experimentation, because depending on how much he's on, as soon as they start hemofiltration or dialysis, his blood pressure drops. I get that. Maybe, here's another hint, usually 5 liters, that's a lot. Another hint is sometimes hemoglobin can be low, the red blood cells. He might need a unit of blood or two before going on dialysis or hemofiltration, right? That might help as well. But Leo, if they're removing 5 liters, that is a lot. That is a lot. There needs to be a more gentle approach. Okay. Let's come to Casey's question. Casey says, "Hi Patrick, my name is Casey. My boyfriend suffered global hypoxic brain damage. He responds to pain and perla and has a strong cough. He has a tracheostomy, doesn't follow commands, and the doctor says bad things. How can I help him?" Okay, very sorry to hear that, Casey. Few questions here. How many days ago, was the brain damage? Why does he have brain damage? Did he have a cardiac arrest? Right. How many days ago was that, and what was the reason he ended up with the hypoxic brain injury? I also need to find out what is perla. I don't know. I'm not sure whether you're referring to pupils equal and reactive to light. I am not sure about that, but I will find out what perla means. Yeah, pupils are equal. Okay, yeah, okay, I get it. The other question is he still on sedation? So this happened on February the 10th. Overdose and cardiac arrest 3 weeks ago. Pupils respond to light. Okay, right. So the doctor says nothing but bad news. Say he will progress to permanent vegetative state. He still has brain activity and suffered severe myoclonus that had gotten better with time. Okay, sure, okay. Does your boyfriend few questions here, Casey. Does he have seizures? That's number one. Does he have seizures? Number two, have you spoken to a neurologist? Pupils respond to light. No, they weaned him off sedation, but he hasn't really woken up. Okay, how many days ago did they stop sedation? How many days ago? And also, is he in kidney or in liver failure potentially? Right? So how many days ago did they stop sedation, and is he in kidney or liver failure? Okay, so it's not in kidney or liver failure. That's good. How many days ago did they stop sedation? And also sedatives. And also opiates. How many days ago? Okay, neurology was consulted. Have you spoken to them? Right? It's one thing to consult them, it's another thing to talk to them. 7 days ago. Okay, that's quite a while ago. Okay. Are they mobilizing him? Are they getting him out of bed? All his other organs are working fine. Okay. Are they mobilizing him? Have they started physical therapy, and are they getting him out of bed? That is going to be very important, getting him out of bed and getting him physical therapy. That's going to be very important. Have they started doing that? Is he getting out of bed, and have they started physical therapy, Casey? Right. Well, he's still on the fentanyl patch, so when I ask for neuro, they haven't seen me. Okay. Well, he needs to get rid of the fentanyl patch. Why would he be on a fentanyl patch? Why? There should be no reason for him to be on the fentanyl patch. Yeah, he needs physical therapy. So he's not getting physical therapy yet. He absolutely needs physical therapy. And why is he on the fentanyl patch? If he's in a quote unquote vegetative state, that doesn't mean that means he has no pain. Why would he need a fentanyl patch? Why? Get rid of it. I ask about it and they look at me crazy like he can't do physical therapy. Well, he can't do it by himself, but someone needs to do it for him. A good ICU will do that. They will start physical therapy and they will get him out of bed. There should be, if he doesn't have any fractures, if he's not waiting for surgery, if he's hemodynamically stable, if all his other organs are stable and his vital signs are fine, there should be absolutely nothing stopping them from getting him out of bed. They're just lazy. They're just lazy and complacent. That's what they are. I have nothing to add here. It's hard to say whether your boyfriend will improve or not. What I will say is this: him not getting physical therapy, him not getting out of bed, him not getting mobilized, he will never improve. That is for sure. I just wanted to see how I can help him now and what questions I need to ask. Those are the questions for now. I would imagine he has had the CT scan of the brain, he has had an MRI scan of the brain, he has had an EEG of the brain, and if he's not waking up, the fentanyl is making people dopey. Get rid of it, unless you or they think he's in pain. But that's not what I'm hearing here. It doesn't sound to me like he's in pain. Yep, so what you can do, Casey, is you go to our website at intensivecarehotline.com. You can either call me on one of the numbers on the top of the website, or there's a button on the website, book appointment, and you can book a call with me there. I offer a free 15-minute phone consultation or a Zoom or Skype, and I have paid consulting and advocacy options beyond that. I'll just type in the website here. Hang on. You can contact me through that website. Just call me on one of the numbers or book a call with me there. I just posted the website here. Okay, what other questions are there from anyone here? Please type your questions into the chat pad or join me live on the show here through this link. You can join me here through this link. I'll be going for another 15 minutes. So I still have time for some questions to answer. If not, I'll just read out the questions that have come in during the week via email. So I'll just, yes, been watching a lot of your videos. That helped me tremendously. That's great. That's great. So, okay, what other, one comment that has come in this week is from Purdy, who said, I am intimidated into the ICU team choosing to take my sister off life support. Wow. So you choose to be intimidated by them. That is a choice you're making, and it's not a good choice. So you can't control other people. You cannot control other people. Forget about it. What you are 100% in control of is how you react. That is what you are 100% in control of. And you choose to react to be intimidated. That is your choice, and it's not a good choice. Another choice would be you feel empowered to stop them from taking your sister off life support. You know, it's about reframing how you look at the situation. Just reframe it and say, I am empowered to stop them, to stop the ICU team from taking my sister off life support. So that is a choice you can make, and you can make that choice now. You don't need to wait any longer, but to make the choice now. Now, here's a good thing. If patients are being taken off life support without patient or family consent, you know, that could be perceived as a number of things. Could be perceived as euthanasia, could be perceived as murder, you know, could be perceived as medical negligence, right? Again, this is a choice that you are making, how you react in a situation like that. You need to get educated, and you need to get educated about intensive care as quickly as possible. You need to get educated about your rights. You know, ICUs do not operate in a vacuum. You know, when it comes to end of life in particular, they do not operate in a vacuum. They operate within policies, procedures, laws when it comes to end of life, right? So this is a choice that you're making. If you feel intimidated, that is a choice that you're making. You can change that perception, you can change your approach, and you can do that right now, here and then. What I would strongly recommend you do is get help, and, you know, let us look at medical records. Let me talk to doctors and nurses directly. Let's ask all the questions that you haven't even considered asking. You are not even scratching the surface in a situation like that, you know, because you probably don't have enough information. Have you looked at alternative treatment options? You know, are there other treatment options there for your sister? Probably, you just don't know them yet. A lot of it also comes down to, you know, I've been talking about real versus perceived end of life situations, and I've been talking about that for a long time here on my blog. You know, is your sister in a real or in a perceived end of life situation? What's the difference? Well, the difference is a real end of life situation means that no treatment, no surgery, nothing can save your sister's life. Full stop. A perceived end of life situation is when there's a perception that end of life might be imminent, might be your sister might be approaching end of life. That perception might be there. But is it that? Is it just a perception, or is it real? You know, a perception is that the ICU team doesn't want to offer any treatment, you know, and then it's a perceived end of life situation. So if the ICU was to offer treatment, your sister might be going on to live, you know. But it's very difficult for families in intensive care to work out whether it's a real or a perceived end of life situation. Very difficult. You need to have the experience, you know, to work out, you know, what situation it is, right? So let's move on to the next question, or you can type your questions in the chat here, or you can join me live on the call. Let me just bring up some other comments and questions that have come in. Hang on. Here is a comment from Natalie, who says, "Hi Patrick, I am frustrated that they still haven't tried to get my mum off the ventilator in ICU. Right. Again, not a lot of context, but I can understand that it is very frustrating to watch your loved one being on a ventilator and you feel like nothing's happening in her moving forward. So the question here is this, you know, is your mom having a breathing tube or is she having a tracheostomy, right? Is your mom, if she's having a breathing tube, is she still in an induced coma or is she awake? If she's awake and she's not in an induced coma, you know, what's stopping them from trying to wean her off the ventilator, right? Is she not awake enough? Is she on too much support? You know, what's stopping them? What's stopping them from even trying, right? Does she have airway swelling? You know, does she have a brain injury? What's stopping them? If she has a tracheostomy, again, the same questions. What's stopping them? Can she not get mobilized? Is she on too much support? Is she still on sedation? Is she having seizures? You know, and again, what questions are you asking? Are you asking the right questions? That's another consideration. Are you asking the right questions? You know, it doesn't sound to me like you've got a very good handle on the situation because, you know, otherwise you would give context. It's very important to give context, but it's also difficult to get context unless you understand the workings of intensive care, unless you understand the ins and outs of intensive care, unless you understand what questions you need to ask, what you're looking for, what you need to look for, and so forth. Right? Very, very important to ask the right questions to begin with. All right, let's move on to the next question and comment that's coming in, where, again, Jade is saying, I'm frustrated because the doctors are telling me different things about my dad in ICU. Again, who do you listen to? You know, who do you listen to? Do you have access to the medical records so that you can get a third party to give you an independent opinion, a second opinion? Also, who are the doctors you're talking to? You're probably talking to the ICU doctor. Are you talking to a specialist as well? Who are you talking to, right? And do you have someone talking to them that can ask questions, the right questions, like myself, right? I can ask the right questions to them. I can ask the clinical questions that you probably don't know what to look for. You don't know what questions to ask. But very important in a situation like that is that you get a second opinion. Here is another frustration that we have from Nola, who says, I am frustrated because they want to remove life support on my husband. Again, similar to the comment that I just read out a minute ago, where Purdy said, I'm intimidated that they choose to take my sister off life support. Again, why are you even agreeing to remove life support? If you are the power of attorney for your husband, no one should be removing life support without your consent. I'm assuming your husband is not in a position to give consent, right? So have you exercised your options? Have you exercised your rights? Most families don't. They don't exercise their rights. And that's the biggest problem, you know. I mean, I've been preaching here for over 10 years and some people still don't follow my advice, even though it's proven advice. You know, you just need to watch the videos, you got to read the blog, you know. And and they still don't follow advice, and then they're wondering why they're not getting the outcomes they want. You know, everything that I do here is proven. We've helped so many families in intensive care over the years, probably thousands of them, getting what they want. Have a look at our testimonial section. Have a look at our podcast section, what our clients say about how we help them, and, you know, that we have saved lives just with my consulting and advocacy, prolonged lives. Or in a worst case scenario, getting the in a worst case scenario, getting an end of life situation on your terms, not on the intensive care team's terms. You know, it's all about you taking responsibility for the outcomes. That's half of the battle. You know, if you come, with all respect to, you know, Dawn comes here earlier and says, you know, oh, they're forcing us to do this, they're forcing us to do that. You can choose to live in that reality. That's your choice. Or you can choose to say, well, I'm going to make things happen, and I'm going to, you know, I don't like forcing people, but I'm going to make things happen for my grandmother, for my spouse, for whatever. You know, because most families that get outcomes and get best care and treatment, they don't make excuses. They get help here from intensivecarehotline.com. We'll show them how to put things in place. We help them to put things in place, and, you know, they get outcomes. It's all about taking responsibility and getting help. You know, asking help is a skill. Asking for help is a skill. It's a skill that families in intensive care need to develop, and they need to develop it very fast. Very, very fast, as a matter of fact. Because they don't have much time. They do not have much time. Okay, so I'm going to wrap this up here for today. I do want to thank you for coming on the show. I do want to thank you for your questions here today. I do want to thank you for your support. You know, because of so many families need help, that's why we created a membership for families of critically ill patients in intensive care. And you can get access to the membership at intensivecarehotline.com by clicking on the membership link, or by going to intensivecaresupport.org directly. In the membership, you have access to me and my team 24 hours a day in the membership area and via email, and we answer all questions intensive care related in the membership. You also get access to 21 videos and 21 ebooks in the membership that are exclusively accessible for our members, and you have all your questions and strategies answered in there. I also offer one-on-one consulting and advocacy for families in intensive care. And I talk to doctors and nurses directly. I talk to you and your families directly. And I ask all the questions to the doctors and nurses that you haven't even considered asking, but must be asked when you have a loved one in intensive care. I make sure you have all the tools, scripts, tips, and strategies that will help you to make informed decisions, have peace of mind, control, power, and influence. We also offer medical record reviews in real time, so that you can have a second opinion in real time. We also offer medical record reviews after intensive care if you have unanswered questions, if you need closure, or if you are simply suspecting medical negligence. I also represent you in family meetings with intensive care teams. I represent you there. I make sure your loved one gets best care and treatment, but I also strategize with you whether going to a family meeting is even the right strategy to begin with. You know, if you need intensive care at home, go and check out intensivecareathome.com. With Intensive Care at Home, we're providing a genuine alternative to a long-term stay in intensive care, long-term ventilation, tracheostomy for adults and children, BiPAP CPAP ventilation, tracheostomy care for no ventilation at home, BiPAP CPAP ventilation, seizure management, home TPN, home IV potassium infusion, port management, central line management, PICC line management, as well as Hickman's line management. Also palliative care at home. With Intensive Care at Home, we're currently providing services all around Australia in all major capital cities. We're NDIS approved, TAC approved in Victoria, iCare in New South Wales, and IISQ in Queensland, as well as DVA all around the country. We have received funding through departments of health and public hospitals as well, and private health insurances If you need help with intensive care at home in Australia, please reach out. If you need help in the US or in the UK with intensive care at home, please contact us as well. We can help you there privately. And for intensivecarehotline.com for consulting and advocacy, go to intensivecarehotline.com, call us on one of the numbers on the top of our website, or simply send an email to support@intensivecarehotline.com. If you like my videos, subscribe to my YouTube channel for regular updates for families in intensive care. Click the like button, click the notification bell, share the video with your friends and families, and comment below what you want to see next, what questions and insights you have from this video. Thank you so much for watching. This is Patrik Hutzel from intensivecarehotline.com and intensivecareathome.com, and I will talk to you in a few days. I'll also do another YouTube live next weekend at the same time. Take care for now.